Hello, and welcome back for another episode of the Go Bronchi podcast. I'm back with another special episode, this time of our Medical Literature Review Club. For this meeting, we're discussing a review article about APRV, and in particular about a very specific approach to APRV called Time-Controlled Adaptive Ventilation, or TCAV for short. This article was written by Dr. Hassan Al-Khalisi et al. And was published in the Journal of Respiratory Research in 2024. We will have a link to the article in the show notes, so if you would like to check it out, please do. We will also have some links to some other resources that are mentioned by Jamie later in the episode as well. So be sure to check those out too. And without further ado, let's go ahead and get into this awesome discussion. Hope you enjoy it as much as we did.
Well, welcome everybody. Welcome to the Medical Literature Club, the spring edition, March 2025. Thank you all for coming and partaking and listening in. This is myself, Jamie Cappiello, and Professor Jessica Foreman Starks. Jess?
Hello, everyone. Hello.
Well, hello. I guess we'll get right into it. I also want to give a shout out to our Go Bronchi podcast on Spotify. Whoever listens, thank you for listening. And for those of you that listen, please share it. Last month, we had Professor Jessica Foreman Starks, who just did one on chronic obstructive pulmonary disease. We also, our most recent issue, was a Mr. Bob Petrie, a former student of our program. Excellent stuff about respiratory therapy here. Respiratory care information and excitement is not just found in respiratory care and the AARC. It's also found from this outstanding network of the Go Bronchi Nation. So go Bronchi. All right, enough of that plug. All right, to review club objectives, we want to increase awareness of the subject reviewed. Now, just to give you a heads up, we're talking about APRV tonight, a subject that I'm not very familiar with it. I've never used it clinically, but I have used inverse ratio ventilation. I know the two are not interchangeable, but I just wanted to give you that transparency. The club also wants to demonstrate the evolution and development of medical knowledge, review the validity, value, and applicability of the presented article. This particular piece is a review article. Review articles, we know in evidence-based medicine, if we look at that pyramid of strength of evidence is not high on the strength of evidence, well, we're not looking for a strong piece of evidence. We're looking to increase our knowledge. I love review articles because if they're well written, they are a wonderful source of information. And we see that in the references that they use and how they present it. All right, so I think this is a really poignant article for those of us who aren't very familiar with APRV to really understand or help direct us to understand the nuts and bolts of APRV. All right, and then we want to provide a professional discourse and opportunities for engagement, which we do during the discussion. All right, so why was this chosen? Well, I just mentioned about the medical literature. There's, if we look at textbooks and all the information we get in order to become practitioners or whatever we end up becoming, that textbook information comes from the medical literature. Over time, that medical literature is gleaned for what works, what doesn't work, and creates practice standards. Those practice standards is what's in the textbook. So if we're looking to what's going to be in the textbook in 5 years, it's in the medical literature. If we want to help create textbooks, then we need to be aware of and use the medical literature. The other reason was ARDS mortality. It's not going anywhere. It's very high. It's, I don't know, too high, one could say, but we haven't really made much advances on it. So as respiratory therapists, we're so intimately entwined with mechanical ventilation and ARDS. So it's important that we know as much as we can about it. And then change management, science, and the respiratory therapist. Well, I already mentioned how intertwined we are with mechanical ventilation. If we want to maximize our efficiency, if we want to improve patient outcomes, then we need to know as much as we can because we're not the only ones involved in critical care patients. We're one of a number of disciplines. And if we have a unique skill, a unique knowledge base that we can afford the team for improving care or changing care or being receptive to, what do we usually say towards the end of codes? Does anybody have any ideas? All right, so that's the other reason why this article was chosen. All right, bear with me on this timeline. This is all designed to help set up the table for Jessica's talk. Also, don't quote me on these years, but back in the 1960s, that's when invasive mechanical ventilation really started. The bedside ventilators were developed, and ARDS was identified as a syndrome. In the 70s, PEEP came out, hitting mortality significantly, and so PEEP exploded, being used everywhere. In the 1980s, we started realizing this baby lung concept where we had unhealthy lung and healthy lung, and that it is best if we breathe towards the healthy lung. In the 1990s, a lot of work was done based on the baby lung concept. And I have a little happy face there because even though there isn't anything special that came out of it, a ton of special things came out of it. In the 1990s, we saw an increased use of, or the development of APRV. We saw the oscillator being reused. We saw non-invasive ventilation really changing the face of length of ventilation days. There's a lot of intricate things. We had unique work being done on should it be tidal volumes of 6 mLs per kilograms, 10, 12 mLs per kilograms? How high should we go on PEEP? How aggressive should we be with hyperoxia or keeping the PO2s lower above 55? So we got a lot of good information from the 1990s, such that when we hit the 2000s, we were pretty confident that low tidal volume ventilation or even the open lung approach really helped prevent ventilator-induced lung injury. The goal was to brief the patients to prevent ventilator-induced lung injury. Well, in the 2010s, we really got aggressive with figuring out whether or not the oscillator was a generalizable mode of ventilation. We found that it wasn't generalizable. It's not to say it didn't work, but it wasn't generalizable. The ECMO, the CESAR trial showed us that ECMO was a viable alternative for those patients in refractory hypoxemia. And we clearly identified that the role of driving pressure was significant. Maybe it wasn't so much the tidal stretch, that the driving pressure was more important, and we started focusing on compliance. And then the 2020s, we got inundated with COVID and the results from prone studies that showed a significant improvement in mortality when we placed the refractory hypoxemic patient in prone. So that's kind of it in a nutshell over the last 60 years, and that's quite a long period of time. But the main focus today is mechanical power and the compliance of the lung. But I want you to note that over the last 30 years, the mortality for ARDS really didn't change much, right? Mortality only dropped a little bit more than 1% per year since 1994. And the current pooled rates of mortality for ARDS are 43%, with mild ARDS having the best, moderate around 35%-ish, and severe around 47%. Right? So ARDS is significant. And what we have to recognize is we have to think, how can we minimize drive pressure, right, while opening and stabilizing the alveoli? Because that's all what we want, right? We have PEEP here to open the alveoli. We had the oscillator here that had such good impact that we said, let's try to do a big study. ECMO, we basically said we can't keep the alveoli open. So how do we keep the alveoli open and stabilize? All right, let me give you this case report. Now, this is from a posted presentation at a chest conference in 2024. We have a 50-year-old male with a BMI of 40 who needs aortic valve replacement. He goes in, has it done, comes back from the OR. He's hypoxic with a PO2 of 71. He's on 100% oxygen, and he's on a PEEP at 12. Right? You have a couple of red flags there, right? PEEP at 12, BMI of 40, 100%, refractory hypoxemia. So what do we do? Well, we can reverse Trendelenburg him. We could optimize PEEP. We can prone him, and we can put him on ECMO. Those are all the options we have, right? We don't have any other options. Well, according to these authors, they did have another option, right? They employed APRV with the TCAV protocol, right? Now, it's important that we're focusing on this TCAV protocol because that's how we're going to set the APRV. Proning was avoided. Remember, proning wasn't an option for somebody who's post-op median stenotomy. Why wasn't the PEEP increased or reverse Trendelenburg used? We don't know. This is just an abstract, but this is where the authors went. And interestingly enough, this APRV, which claims the high mean airway pressure in this cardiothoracic environment, was used successful, and the patient extubated and went home. Everything was beautiful. All right. So what does that mean? Well, if we look at CO2 removal across the three modes of ventilation, standard ventilation up top have pressure control, but it could very well be volume control. We have the oscillator here, and we have APRV. These are the points of CO2 removal, and these are the points of oxygenation, right? The FRC is created basically from the PEEP. basically from the mean airway pressure and from the APRV, basically from the mean pressure, or, well, what we're really looking at is time. Time is what's making these great oxygenation improvements from these two modes of therapy. Okay. And it's important to recognize this time factor because that's something that we really haven't addressed with other modes of ventilation, like pressure control, open lung approach, or low tidal volume approach. We're not thinking about the time it takes for the pressure to distend or the gas to distend to the alveoli. They don't live in an open air environment. They're not balloons. They live in a viscoelastic environment. So it takes time to get pressure down there. So if we look at the regular lung, the basic lung, getting a breath, we see areas of wonderful inflation, wonderful compliance, but we have these dead areas here. All these areas here are contributing to the shunt and making our PO2 low. And where these easily inflatable areas meets these dead areas, we're causing villi. We're causing ventilator-induced lung injury. So with each breath, we have shear stress causing ventilator-induced lung injury. All right. The oscillator itself has been designed or is designed to keep us out of this atolech trauma region and out of this volume trauma, barotrauma region and breathe in a safe environment. And so does APRV. APRV is designed just as the oscillator is designed to breathe above the zones of atolech trauma and below the zones of barotrauma and volume trauma. If we look at this lung model, beautifully expanding, nice and pink, right? The red areas where it's not expanded yet, but over time, we see them starting to expand. This could be a video of APRV or a video of the oscillator, but this is in fact a video of APRV, creating stable alveoli. All right, and with that, I turn it over to Professor Starks.
Excellent. Thank you, Jamie. As you mentioned, part of the reason why we chose this particular article was really to raise our awareness and have some discussion about APRV because it's a mode of ventilation that is not used too often. I think it's getting used more often these days than perhaps in the past. But overall, it's something that I think most respiratory therapists would want to know some more about, and would be interested in, learning some more and perhaps implementing it in their own practice where appropriate. But part of the problem with implementing APRV is that people don't quite know where to start. They don't know what settings to begin with. How should we set our parameters, such as time high and time low? I think it's generally pretty well understood that we want to keep that time low pretty short to avoid recollapse of those alveoli that we've just spent all of that time recruiting. But without an approach such as this one, this time-controlled adaptive ventilation, sometimes we're just kind of arbitrarily setting the time low. And I think this approach offers us a pretty good way to think about it from a physiologic perspective and to come at it with a little bit more of an educated perspective in setting those settings. So kind of like what you talked about there, Jamie, the main problem with ARDS is that it's one of heterogeneity. We have different portions of the lung performing differently, right? We have the normal tissue, which we sometimes refer to as the baby lung. So that's the portion of the lung that's acting fairly normally and is able to participate in gas exchange fairly normally. But then we have the injured, unstable lung tissue that, is obviously injured by the ARDS process and all of the inflammatory things that go on. And this unstable lung tissue is very susceptible to that repetitive alveolar collapse and expansion type of injury, that shear collapse and shear injury that we really want to avoid. And so that's where the problem in ventilating really comes in with these patients, is that we have different levels of compliance throughout the lung, that we really we can't target one area over the other necessarily. And so we have to find a way to balance and stabilize all of it. As is mentioned in this great visual here, the section on top is really an area of more normal tissue that has a more normal compliance, or at least an easier compliance. And those portions of the lung are very likely to become over distended when we are trying our more aggressive modes of ventilation. Because, of course, we know that air and pressure is going to go the path of least resistance. And it's got the less amount of resistance, got better compliance in that normal lung tissue. So that's where a lot of that ventilation is going to go. But then as we get down into areas like C and even A, where we have uneven expansion, we've got portions of collapsed lung. We have surfactant inactivation going on as well, making it very difficult to recruit these. Again, it's very difficult to get the air to go there, to be able to even recruit these alveoli. And then it's going to be important to try to maintain that recruitment so we don't have that shear reopening effect going on. So, like we've kind of already talked about a little bit, we have really two main approaches these days to lung protective strategies. We have the low tidal volume strategy that most of us are fairly familiar with, and then we have what we would call the open lung approach. And we know with our low tidal volume approach that our primary aim here is really to prevent overdistension and barotrauma to the existing normal lung tissue. We're trying to minimize extra injury to the already normal lung tissue. And really, we're trying to prevent, again, that reopening injury in that damaged lung tissue. But part of the problem with that is that the mechanics of the damaged tissue are changing all the time, and collapse can gradually recur over time. So even if we have been able to recruit certain sections of the lung over time and without the proper maintenance of pressure over time, we can get more collapse recurring again. And this low tidal volume approach effectively kind of rests the collapsed lung tissue. When we're following this approach, we're saying, yes, we want to try to recruit as much of the recruitable lung as possible, but if we're not able to get to those collapsed lung areas, we're going to use our normal baby lung to perform most of our ventilation. But the problem with that is that collapsed lung tissue remaining collapsed is not benign. This is not something that it in itself can create more inflammation and lead to other pathologies such as fibrosing alveolitis. We have more inflammation that then impacts the surrounding tissue. So we have this gradual worsening of the less injured tissue that's around this collapsed lung tissue, but it tends to spread out, right, with this inflammatory process continuing. And additionally, it also increases the pulmonary vascular resistance, which puts more cardiac strain, especially on that right side of the heart, um, which of course is going to compound everything if if our heart starts failing as well. But the open lung approach, which I believe APRV and even high frequency would fall under, really focuses more on trying to recruit as much lung tissue as possible and to sustain that recruitment, really preventing recollapse. And this is where that time portion of things comes in that Jamie, you were talking about before. It's not just about using the right amount of pressure. It's also about allowing enough time for that pressure to reach all of those other collapsed areas to have that recruitment effect. However, some portions of this where especially if we're using recruitment maneuvers, which I don't think a lot of us are doing too much anymore these days, but if we are, oftentimes we're really trying to recruit too quickly with this open lung approach. We're applying too much pressure over a too short amount of a time, and we don't allow that pressure to be able to get to all those little nooks and crannies, if you will. And also, unfortunately, the open lung approach has not necessarily been shown to improve mortality compared to our traditional low tidal volume approach. So we're left with both of these that each have their own caveats and their own benefits. But that's where we're going to get into talking about this open lung approach a little more now. So this time-controlled adaptive ventilation that this review article goes over does a wonderful job of it. Honestly, if you have not read the article yet, I would highly recommend it. This is an approach to setting APRV where the time low is set based on the patient's compliance. And they recommend that the T-low ends at 75% of expiratory flow. And this might sound kind of familiar. This is a concept that we've seen in non-invasive ventilation. I believe it was the V60 that was able to do peak expiratory flow as a means for cutting off inspiratory time. But in this case, we're talking about our exhalation. So our time low is that short window of time where we allow the pressure to drop and we allow exhalation to occur, and that's where we get our CO2 washing out. And the recommendation here of ending at 75% of expiratory flow, you can see over here on these graphs that the angle of this is different for each of these patients. With this normal lung here in green, you can see that we've got a more gradual slope, right? But all the way up to our red in severe ARDS, we have a very steep slope because we have very poor compliance. So the lung wants to recoil very quickly and collapse if it's able to. And so by setting that T low specifically at 75% of the expiratory flow or thereabouts, we allow for maximum exhalation of CO2 while still preventing recollapse of the lung that we just recruited. However, this is going to require constant monitoring and adjustment with changes in compliance because, again, we have that heterogeneity going on with ARDS. We have a constantly changing situation with this particular pathology. So it's not something that we're going to be able to just set and forget all the time, right? We'll need to be watching this and making adjustments as things change. And of course, as the compliance worsens, the shorter our T low is going to be to try to maintain that recruitment. The long time high is what allows for maximum recruitment of the alveoli, and it does this slowly, like we were just talking about on the last slide, about allowing that pressure to be maintained for a long enough time to really recruit those other areas of the lung that we haven't been able to recruit before. And that short T low prevents collapse, of course. And this particular image here, I took actually from the article itself. I think it does a really good job of kind of showing this inflammatory cascade and this, they call it the villi vortex that we get ourselves into with ARDS, and in particular with the low tidal volume strategy a lot of the time, where we have a change in lung compliance. We have that fixed tidal volume with our low tidal volume strategy. And of course, it's going to be redistributed as compliance changes, and that volume is going to go the path of least resistance. But then we get damage to the recruited alveoli because of that redistribution. So we have all these recruited alveoli that are allowed to collapse when suddenly we have that redistribution. So we get alveolar collapse, which leads to more change in lung compliance, a worsening of our lung compliance. We get further redistribution of that tidal volume and further damage until we have just gone down this vortex to really severe ARDS. And the approach that they have described here in this article um, really is about catching those changes in compliance and changing with the changes in compliance to try to stabilize the lung. As we are able to adapt the settings to fit those changes in compliance, the idea is that hopefully we are able to recruit more lung and stabilize more lung, preventing this whole villi vortex that we have going on here, hopefully going in the opposite direction, um, swirling up to much better situation. And this particular image here, I took actually from the article itself. I think it does a really good job of kind of showing this inflammatory cascade and this, they call it the villi vortex that we get ourselves into with ARDS, and in particular with the low tidal volume strategy a lot of the time, where we have a change in lung compliance. We have that fixed tidal volume with our low tidal volume strategy. And of course, it's going to be redistributed as compliance changes, and that volume is going to go the path of least resistance. But then we get damage to the recruited alveoli because of that redistribution. So we have all these recruited alveoli that are allowed to collapse when suddenly we have that redistribution. So we get alveolar collapse, which leads to more change in lung compliance, a worsening of our lung compliance. We get further redistribution of that tidal volume and further damage until we have just gone down this vortex to really severe ARDS. And the approach that they have described here in this article really is about catching those changes in compliance and changing with the changes in compliance to try to stabilize the lung. As we are able to adapt the settings to fit those changes in compliance, the idea is that hopefully we are able to recruit more lung and stabilize more lung, preventing this whole Villi vortex that we have going on here, hopefully going in the opposite direction, um, swirling up to much better situation. And with that, I'm going to pass it back over to you, Jamie.
Well, all right. So, what patients is APRV for? I'll open up the floor if anybody wants to weigh in, but right off the bat, I want to mention that we're not trying to be flippant about the ARDS term. What we're looking at is refractory hypoxemia. So, ARDS is based upon a P to F ratio. If you want to use the Berlin criteria, it's just looking at how many quadrants of infiltrates do you see in the chest X-ray. So, what patients is APRV for? Like you saw that case study I said earlier with that patient, post-op cardiothoracic patient. They fit severe ARDS just by that Berlin criteria. No mention of what the chest X-ray looked at. But if we're looking at refractory hypoxemia, what are our goals? And that's where you have to start looking at the individual patient and what type of settings or what type of modes of ventilation you're using for the patient. So you practice the low tidal volume approach, you practice the open lung approach. The mechanical ventilator is not always the only reason why there's an issue with oxygenation, but you have to rule out things and make sure that, yes, this is something going on in the lung. So APRV, who it's for, is patients in refractory hypoxemia. So I think that's who APRV is for, the patient in refractory hypoxemia. Why isn't it popular? Did anybody online use APRV? You can raise your hand or you can unmute and join in. Well, I'll tell you right off the bat, I've been a respiratory therapist for almost 45 years. Oh, Jody, go ahead. You want to unmute?
We use it on occasion. The problem is that we don't use it. Can you hear me?
Yes,
Okay.
yes.
The problem is that we don't use it until like the last ditch effort, and so we don't use it frequently. Nobody's really that good at setting it up and maintaining it. And then we've kind of like overweighted until it's a little too late to use it.
Yes.
So
So,
we aren't having good outcomes, I guess, is what I'm trying to say.
right, I got you. APRV is not a silver bullet, so to speak. We can't think that it is. No mode of ventilation is going to be a silver bullet. But what I think is important is that, as you mentioned, we wait too long to use it. Well, do you have a protocol for refractory hypoxemia?
We're just getting a like an oxygen protocol and a ventilation protocol up and running at our facility.
Right.
So not specifically like a refractory hypoxemia protocol. No.
Right. And that's what I think the benefit of this discussion or this paper or APRV is everything that I've done to prepare for this little chit chat, um, refractory hypoxemia is unique, and we know that the patient's going to either end up on ECMO or for an ECMO referral or an end of life situation. We know that proning is beneficial, such that every ECMO center, when they're getting a referral, will ask the institution if they've tried recruitment maneuvers or if they've tried proning the patient. All right, they won't accept for ECMO until they've already tried, so to speak, advanced mechanical ventilation techniques. Well, where does APRV fit in? And I can assure you from everything I've read, APRV does fit in there as, I hate to say last ditch effort, but something worth trying and doing. Now, you mentioned that your experience is that your institution has waited too long. Well, when do we recognize refractory hypoxemia? Is it at 60% oxygen and a PEEP of 15? Or do we wait until the patient's on 90% and a PEEP of 18 and they have rising CO2s? So I think in any refractory hypoxemia protocol or advanced mechanical ventilation protocol, you need to have a clear definition of when you're going to label a patient as severe ARDS or even moderate ARDS. When do you want to start using your advanced techniques? Is it moderate ARDS and severe ARDS? And something I'll mention later on that addresses this. All right. Jody, you have anything else you want to add?
No, not yet. Maybe
Okay.
later. I was gonna talk
Okay.
about ECMO and like how you mentioned that ECMO is like it's not supposed to be used until like other therapies have been exhausted.
Yeah.
I feel like we're using it like right away.
Well, yes. Okay. So if a candidate's a strong, yeah, I'll touch on that now. If a candidate's a strong, if you have a patient who's a strong candidate for ECMO, the earlier you get them on, the better, because you don't have this ongoing lung damage. So what you're waiting for when you're resting the lung and they're on ECMO is for the lung to heal. Now, with that being said, and I hate saying with that being said, the more damage you do to the lung, the longer it takes to heal. And that's why if you're at an ECMO center, if you have a patient on 80% PEEP of 18, they're more likely to go on ECMO only because they're there, they can, and the evaluation of the patient is such that the lung damage is not going to clear within 24 hours. So some places will have on their protocol that they have tried a steroid burst as well as proning. In some places, a little bit less. It depends on how aggressive your ECMO program is.
That makes sense.
Dean, is that your experience?
Yes, I would agree with that.
All right. Okay, what are the drawbacks, risks of APRV? Well,
I think we've talked about a bunch of them already.
yeah, I think the biggest drawback of APRV is what Jody mentioned. Jody, you want to weigh in on this or?
The drawbacks of it, nobody knows how to use it. At least
Yes,
work. We're not good at it.
Definitely.
I agree that that's the biggest drawback. And I have to applaud Jessica for saying, hey, Jamie, let's do this article because this article actually tells you how to use it. It's not that difficult. It really is funny. Um, I have had many conversations with a few pulmonary critical care physicians about APRV. And their primary issue was nobody knows how to use it. And that's difficult. That's difficult for me as a respiratory therapist to hear. And I'll touch on that later when it comes to change management. Is APRV a rescue mode? Yes and no. It doesn't have to be. It doesn't need to be. It definitely is. It's definitely, I think, has a role in refractory hypoxemia to determine whether or not a patient should go on ECMO. Are there plenty of case studies and literature that says patients had failed lungs, were on ECMO, and then were rescued on APRV such that they did not need a lung transplant? Now, lung transplants, I worked at a lung transplant center. They're great. They're wonderful. They're difficult. They don't always do well. So if it can be avoided, yes, I'm all in favor of it being avoided. So what are my professional obligations regarding this mode, or what are our professional obligations regarding this mode? As a respiratory therapist, we have in our purview certain tools, certain pieces of equipment, certain services. And I think if we work in the intensive care unit, I think it's something that we should be familiar with to the point where we can have a conversation with a physician, a critical care intensivist about this mode. Now, in my practice, I'll just, I hate to share stories, but in my practice, the conversations I had about APRV were scratching the surface, asking them what their experience was, or ask them what their positives and negatives about APRV. And my institution never bought into APRV. We were an oscillator center. But as far as the positives and negatives and the possibilities of it, this was always something that I brought up and I found was an interesting conversation. And so, how deep you want to get into learning about APRV, that's up to you. But I think everything that comes across, if you work in an intensive care unit, everything that comes across that has to do with pulmonary medicine is in your purview, and I think you should have some familiarity with it. All right. So should you support APRV? Well, I don't know. I don't know if you should support it or not support it. I think you should support whatever you glean from the literature or glean from the evidence as possibly being beneficial. Is there a silver bullet? No, there's no silver bullet. But I've seen many of pieces of evidence that say there were success stories that makes me think, hey, I'll tell you straight out. When I first started this field, there was no such thing as ECMO. When I first started using non-invasive ventilation, people thought it was crazy that patients should be intubated, and now everybody's on non-invasive ventilation. So I'm scratching my head here, thinking back to the days when I used inverse ratio ventilation, and I see this mode of ventilation being so unique, taking advantage of the intricacies of modern mechanical ventilator technology and getting really down to the physiology of what's happening at the alveoli. How do we reach the alveoli? I saw the benefits of the oscillator, and now I see this TCAV approach to APRV that brings that mean airway pressure to a point where it's stabilizing the alveoli. Gee, I wish I was 40 years old again. So does APRV need to be part of the refractory hypoxemia path? I think it does if you have a protocol on how to use it and your staff and colleagues are well understanding of the protocol. Now, I have some pieces of literature that I'd like to show you that I think will give you food for thought as to how this could be weaved into a protocol. And how does change occur? It changes from your participation. I'm laughing at my dog over here. Yeah, change comes from your participation. It's not just one person. It's I know in one of the classes I teach, I mentioned the word champion. It's starting the conversation. If you have the conversation, then the next thing you know, it's a bigger conversation. You're not just talking to one person. You're talking to two people. Then you're talking to three people, and then you're saying, well, what if we do this or what if we do that? Before you know it, it's not really a conversation anymore. It's a plan. So, that old adage of first take your first step, and then the second step is easier, and the third step is easier. Think of what's you want to do the impossible, think of what's possible. Next thing you know, you're doing the improbable. Next thing you're doing the impossible. So really that is how change occurs. And I'm going to show you some pieces of literature here that, I mean, the scope of APRV is so far beyond what we could cover tonight. But these 7 items here, you really should, just quick screenshot this. I want to tell you this first one is Myths and Misconceptions of APRV, written by really leading authors of APRV. This fella Nieman and Habashi, they really are the subject's leaders in this field. And this really reads like a pro-con debate and answers a ton of questions. This one here, APRV with time-controlled adaptive ventilation in COVID-19. One of the big issues with APRV that con people or anti-APRV people say is, what about self-induced lung injury? Well, because of the COVID, this community hospital really started using APRV TCAV approach because they noticed that their mortality rates with lung protective ventilation were not what they wanted them to be. They were lower, they were worse than what they should be. And so they adapted airway pressure release ventilation with the TCAV approach and had significant improvements. And now this belies one of the myths about APRV that it causes volume trauma or it can cause volume trauma. So they had completely the opposite experience. And there's a lot of information in this article on how they went about initiating an APRV TCAV protocol. This is a nice review article on APRV that also addresses self-induced lung injury. This is a great piece that's anti-APRV. Now, if you're ever going to learn about a subject, don't just learn the pros, learn the cons. And what's interesting is they finish with the same summation as this article, that APRV has a role in refractory hypoxemia. So they say don't use it, but they end up saying it has a role in advanced refractory hypoxemia. This piece here is a wonderful piece. I know I'm going on and on and on, but the first place I think you should start is actually these two places. This is the APRV TCAV website. I'm going to bring you over, let's see, where is it? I'm going to bring you over bear with me. This I downloaded from that website. This is actually a how-to set in APRV. I know there's a lot of words, but after you read it about 3 times, it'll completely make sense to you. And it is something that can be pared down and actually hung on the side of a respirator or even your respiratory annex. All right. So it's the how-to on how to set somebody and even make changes on APRV. But the very first stop would be here. Go to the AARC University. And if you're a member of AARC, this is free. Watch this 45-minute show by Doctors Nieman and Habashi, who I mentioned before up here, on the science and clinical research of APRV using the TCAV method. After that, you can go to these two. So first step here, second steps here. And I think you'll feel pretty comfortable with having a conversation about APRV with your colleagues.
Thank you so much for putting those resources together, Jamie. I think that's super helpful because, of course, we can only cover so much in the context of this short little meeting tonight, right? But hopefully, what we hope people will take from this is some things to think about, some food for thought, and then to be able to go and do your own research to find other resources like these ones that Jamie's provided, to be able to continue that conversation in your own, your own local area, in your own department. I think part of the conversation too needs to, of course, be with physicians too, because the lack of familiarity and the lack of comfort with APRV is not limited just to the respiratory therapists. In a lot of situations, it's also the physicians themselves who are not super familiar with it and are therefore resistant to try it. And I think having something like that protocol that you just pulled up from the TCAV network could be super helpful if you are going to try to come to a physician and say, hey, can we try this? Here's a protocol for how to implement it. I think you're much more likely to get some traction with that as opposed to just trying to have a verbal conversation, to be able to have some resources to back yourself with, right? So I love that you provided those. Thank you so much.
Yeah, I mean, I have to say, just the cons that I've heard from physicians over the years, there really are good answers for them. There's no real good clinical trials, randomized clinical trials about APRV, and people love, this day and age in evidence-based medicine, they love the randomized clinical trial. Unfortunately, they're expensive. They're very, very expensive.
Right.
So, I can appreciate the fact that people say that's a problem, but I don't know if it really is a problem as much as it's just bias. So I put that timeline up earlier to show you about lung protective ventilation, the CSER trial about ECMO, the Oscar and Oscillate trials about the high frequency oscillation. Those were big funded studies, and APRV, unfortunately, is a mode, which means there's no proprietary money behind it. So,
Mhm.
so if you look at the oscillator, there are individual units that can be sold. If you look at
Right. There's money to be made
yeah,
there.
so it's not that there's absolutely no conspiracy theory going on, but there is an investment in industry, and so there's no industry of APRV. There's only the science. And what's unique is every paper I've read knocking APRV, I also see a response from the APRV community being positive about it. And what I think is fascinating is this gentleman Nieman, this physician Nieman up in Upstate Medical Center, who is an intensivist and runs a translational lab. The work that he's done and the people that he associates with are these people that do this heady physiologic studies of ARDS. and he keeps focusing on the time quotient and the compliance quotient. And I think it's a little ahead of the path. It's not sexy stuff. It's not because
Well, and it's difficult to wrap your brain around sometimes too.
yes, but I think the TCAV approach really simplifies it. And I think, Jody, if you download that TCAV approach, I think it might make things a little simpler for you in looking at a refractory hypoxemia protocol. And proning's not that easy. Proning's not that easy. Should people be proned? Yes. I mean, the evidence say prone away. But if the patient fails in proning or doesn't prone, or if the patient's not a candidate to prone, can you prone on APRV? Yes, you can. You can do both. Yes.
Jamie, I'm wondering if you might be open to some discussion about the inconclusive studies that we've seen about APRV. Do you think that there's an element in that of one just being the fact that ARDS is such a difficult condition to even ventilate in the first place? We already have high mortality rates despite our best efforts, right? Do you think that that plays into a little bit of the inconclusive or negative studies that we've seen? And then also, do you think there's an element of familiarity with the mode and an appropriate use of the mode during those trials? I mean, that's something that we have to ask as well. Certainly, are we really comparing it at its best at that point?
Yeah, no, great point. I don't think there are negative studies on APRV. And I'm not embarrassed to say that. I'm not afraid to say it, and I'll tag my name to it. I think the studies that are out there that don't show positive responses to APRV, or even shows that APRV favors a higher risk or higher mortality, were not good studies. Just because it's published in the literature, it doesn't mean it's high quality. It means it's quality. It means it was written by people that are smart and trying to do the right thing. But it's very difficult to do a study cleanly with good comparators. It is very, very difficult, requires a lot of funds. So if you look at the negative outcome studies or the poor study or the studies that said APRV didn't show favorable signs, you have to make sure that you're comparing apples to apples and oranges to oranges. So if you look at APRV with a T low set indiscriminately against a control group of lung protective ventilation, low tide of arm strategy, well, that's not APRV TCAV approach, because the scientists behind APRV say you really have to set the expiratory limb to a point where you're getting this controlled fashion. You want to avoid race. If you allow the T low to be 1 second, 1.5 seconds, 2 seconds, you cause race. So that's not really comparing apples to apples. If you take a group of patients and their Apache scores, or they're much sicker in the APRV group, and you have less sick patients in the control group, well, that's not comparing apples to apples and oranges to oranges. So there are things that you need to look at within these studies to determine, are they really strong controlled studies? And no, there are no randomized control studies out comparing APRV TCAV with standard lung protective ventilation or low tide of arm ventilation or the open lung approach on ventilation. It's interesting. The same reasoning now, looking at micro elements of a subject versus the macro elements of the subject. Let's step back for a second, look at the macro elements of what created these high number Oscar and oscillate trials for high frequency oscillation, right? So a ton of patients and a ton of resources were poured into saying the oscillator is probably going to improve mortality because the oscillator centers had such good experience with the oscillator that they were comfortable saying this will probably translate. We now need to go out in the community and try to translate this and see if they'll have the same benefit. Well, they didn't, because the oscillator is very difficult to use for a number of reasons. One of which is the patients have to be paralyzed, right? When you paralyze a patient, it's not just a matter of giving them a drug and the muscles don't work. it's bigger than that. You also take a patient from a mean area pressure, say, of 20, and you're bumping them up to 32, 34, 35. So it's not that simple. And there's also a time frame where you have to wait and watch. You also have to be cognizant of the potential for abrupt pneumothoraces. So it just didn't translate. But that same mentality, if we look at the physiology of the two modes, breathing above the area of atelectasis trauma and below the area of volume trauma and barotrauma is the safe area, or the area where you get alveolar stability. So if you take a mode like APRV and you structure it to be what's recommended by the experts, which should be Nieman and Habashi, if you take that and you translate it over and compare it to a control group with equal demographics, equal entry points, then you'll get some information.
Mhm.
Any questions? Anybody?
We've got some people in the chat who are having to take off, just saying thank you.
Oh, thank you.
Dean brought up a good point that some places, well, and this is to be expected, that cardiac output side effects are definitely something you have to consider with APRV because, of course, when we're using that high of a mean airway pressure, you're going to have impact on your venous return, all kinds of things related to cardiac output.
Yeah, I don't know, Jess. It's a good point, and Dean, thanks for raising that. That's one of the things that everybody likes to say is, and cardiothoracic is right there, number one, with saying, you increase the PEEP, you're going to decrease venous return. Well, venous return is not that simple. Venous return actually comes from the transmural pressures coming from the lung across into the vena cava. All right, what does that mean? It means essentially that if you have a soggy lung, a dropped lung, atelectatic lung, pressures don't tend to translate as well. But what you definitely do have is you have a right heart that's pumping against a high pulmonary vascular resistance. So I'm going to quick admit Shannon Mays. All right, against a high pulmonary vascular resistance. So if you have a deflated lung, say half the lung's deflated, your PVR is going to be high, and that right heart strain is going to be high. Now, there's nothing sexier to me than the right heart. You're talking to somebody who loves inhaled pulmonary vasodilators, but but if we inflate the lung, right, we now have a happy right heart because they're not pushing against all this soggy, compressed vessels.
That's a good point, too.
Yeah, and so yeah, if you look at how venous return really does occur, it's not as simple as that mean area pressure reading that you're getting on the ventilator. It actually is transmitted through the lung tissue itself and then onto the vena cava. And so yeah, it's not I know it's something that we hear, we say, but it really doesn't translate. Make the right heart happy and you'll make the whole venous
Well,
return.
and there are ways to compensate too. You can increase volume in some cases to try to help with that as well.
Yes, if you're preload dependent, yes, if preload dependent, sure, you just give them a little volume, and that's easily tested by just raising their legs to see if their blood pressure
Right.
improves. Yeah.
Excellent point. Dean is also asking, does this take the concern for driving pressures away?
The short answer, Dean, yeah, actually it does. If you know what, I'll send you the article, but actually if you look at the driving pressure, and the best thing I could do is refer to whoever's online to that AARC University lecture. So what happens with APRV is your driving pressure actually goes down because driving pressure is set on compliance or set due to compliance or per the compliance. And so the driving pressure is the inflation pressure minus the PEEP, right? So the driving pressure in APRV is actually the set pressure versus the pressure at that 75% point of peak expiratory flow. So typically, pretty quickly, when you transition somebody from APRV, you have a lower driving pressure. And the driving pressure and compliance is really the things that we're finding out is what causes Billy. So if all of a sudden you have a lower driving pressure, which it happens on APRV, you're anti-Villi. But then you turn around and somebody says, yeah, but now their tidal volumes, instead of being 60 mils per kilograms, are 80 mils per kilograms. Well, it's really not the tidal volume that's the problem. It's the driving pressure.
Right. It's what it took to get that, right? And we were
Right.
able to achieve that kind of tidal volume with a lot less driving pressure.
Yeah, I mean, think about it. I mean, when you ventilate somebody with one lung, are you ventilating them with 6 mLs per kilogram? No,
No.
no, right? You want to use less. Oh, you want to use 3 mLs per kilogram because he has one lung? Well, now wait a second. You have to think about it. 6 mLs per kilogram is based upon the normal lung mammals of mammals. So that's whether it be a lamb, whether it be a rat, a human. 6 mLs per kilogram we know is the safe region. All right, so let's collapse half of your lungs from ARDS. And so
Right?
now we're giving you 6 mLs per kilograms on this top half of your lungs, when really we should be giving you what? Less.
Right.
6 mLs per right, because none of that volume is going down here. So what you're doing is you're over distending here. But we're all right with that because in 1998, lung protective ventilation says 6 mLs per kilogram. Yes, I'm not saying 6 mLs is anyway wrong, but I'm saying in cases of moderate ARDS and even severe ARDS, we're missing the boat somewhere.
I would agree. Excellent. Does anybody else have any thoughts? Want to chime in? Well, Jamie, thank you so much for being here and for putting this together for us.
Oh, my pleasure. Thank you, Jessica. This is an
Of
outstanding
course.
subject. I'm sorry I soapboxed a little bit. I don't know.
That's all right. This is your platform. You're allowed to soapbox.
All right, everybody. Thank you for coming. Jessica, thank you so much.
Of course. All right. Well, thank you so much, everybody. Have a great night, and we'll see you next time.
Bye now.